Welcome to the Hospital Medicine Unplugged podcast.
Our mission today is a deep dive into one of the most pressing and really evolving clinical challenges we face on the wards.
That's right. We're talking about the inpatient management of opioid withdrawal.
And this issue has been profoundly reshaped by the fentanyl epidemic. I mean, it's forcing all of us as hospitalists to rapidly adapt our diagnostic and treatment strategies.
We're moving far beyond the protocols we used even, 5 years ago? It feels like a different world.
That's absolutely correct. Opioid withdrawal is a critical clinical challenge on our general medical wards. And it's not because it's inherently life-threatening as a standalone condition.
Though it can certainly push a sick patient over the edge.
Exactly. But it's because untreated withdrawal is profoundly, deeply uncomfortable. And crucially, it disrupts necessary medical treatment for the patient's primary illness.
It makes it almost impossible for them to cooperate with care.
Right, and maybe most significantly, it serves as an overwhelming trigger for relapse the moment they walk out the hospital doors.
That focus on relapse prevention and retention in care is really what drives our urgency. So our goal for this deep dive is not just to summarize.
No, we want to synthesize the absolute latest evidence
On recognition, assessment, and the nuanced pharmacologic management that's required for today's high-tolerance patient population.
We want to ensure that you, the hospitalist, can confidently offer state-of-the-art evidence-based care.
Especially when you're dealing with the high potency and, frankly, the unpredictability of illicitly manufactured fentanyl.
This really is foundational work for integrated care. Recognition and, appropriate aggressive treatment of withdrawal is the basis for building a therapeutic relationship with these patients.
And the inpatient setting gives us this unique, highly monitored opportunity for intervention.
For stabilization and then linkage to long-term care that often doesn't exist in the outpatient world. The bottom line is, if we fail to treat the withdrawal aggressively, we sabotage all other medical goals.
Let's start with the hard science then, the foundation of the problem. How do we formally define opioid withdrawal? And what exactly is happening at the neurobiological level that creates this agonizing syndrome?
Okay, so opioid withdrawal is defined as a physiologic syndrome. It occurs after the reduction or complete cessation of opioids in a patient who has developed physical dependence.
So it's purely a manifestation of neuroadaptation.
Exactly. The body, and specifically the brain, adapts to the chronic presence of these powerful opioid receptor agonists. When the drug is suddenly gone, the brain is just left oversensitized and hyperactive.
So if the brain is constantly being dampened down by chronic opioid use, what happens when that inhibitory blanket is suddenly ripped off?
Well, the key mechanism revolves around the locus coeruleus.
Okay.
This is a crucial noradrenergic nucleus located in the brainstem. Normally, opioids act to inhibit the firing rate of these neurons.
Right.
With chronic exposure, the system compensates. It profoundly upregulates its activity and sensitivity to make up for that constant suppression.
And then when the opioid is removed,
That powerful inhibitory tone is instantly lost. The result is a sudden, massive surge in noradrenergic activity. I've heard it called a norepinephrine tsunami, if you will.
and that explains all the classic uncomfortable autonomic symptoms, the sweating, the racing heart, the elevated blood pressure,
Precisely. That's the body's alarm system going haywire.
all because of that norepinephrine spike.
Right. That noradrenergic hyperactivity manifests as the core autonomic signs of withdrawal. You'll see pupillary dilation, lacrimation, rhinorrhea, repetitive yawning, piloerection, what we call goosebumps, diaphoresis, tachycardia, and hypertension.
But it's not just the autonomic system,
No, not at all. We also see critical dysregulation in the mesolimbic dopamine pathway.
which is the primary reward circuitry.
Right. And during acute withdrawal, this pathway becomes severely hypoactive.
And that hypoactivity in the reward circuit translates directly into the severe emotional distress that patients experience.
It does. It manifests as profound dysphoria, a state of deep unhappiness, anhedonia, the inability to feel pleasure, and that intense, overwhelming drug craving that patients report.
So it's much more than just physical discomfort.
It's a fundamental disruption of mood regulation, motivation, and the entire brain's reward infrastructure.
Now, let's pivot to the elephant in the room, the fentanyl factor. The sources are emphatic that the contemporary landscape is fundamentally altered by illicitly manufactured fentanyl.
It's saturated the market.
So what makes fentanyl withdrawal so different and so much harder to manage compared to withdrawal from, say, prescription oxycodone or even older street heroin?
Fentanyl presents, I'd say, three major clinical hurdles. First, its high potency leads to extremely high tolerance levels in patients.
Which means our traditional doses of replacement medications barely touch their symptoms.
Barely. Second, its unique pharmacokinetics. Fentanyl is highly lipophilic.
It loves fat tissue.
Right, so it gets stored and then it's slowly released from these tissues.
And that slow, unpredictable leaching from the fat stores must play havoc with the timing of withdrawal.
It does. It makes the onset of withdrawal unpredictable, sometimes delayed up to 24 hours, and the duration of withdrawal is often extended.
And the third hurdle.
The high degree of tolerance means we require much higher initial doses of OUD medication for opioid use disorder, and we have to implement much more aggressive, rapid titration protocols in the hospital.
So trying to manage fentanyl withdrawal with conservative dosing is a recipe for failure.
A recipe for patient failure and discharge against medical advice, absolutely.
And beyond fentanyl itself, we have to recognize we're usually treating a complex multi-drug picture. The sources really highlight the challenge of polysubstance use.
Absolutely.
Yeah.
Co-occurring withdrawal syndromes are the standard presentation now, not the exception. We frequently see concurrent use of stimulants, benzodiazepines, and disturbingly, xylazine.
Xylazine, the non-opioid sedative that's being found as an adulterant, trank dope.
Yes. And if a patient is withdrawing from fentanyl and xylazine, that completely alters the clinical picture.
How does it specifically change our treatment strategy?
The complexity is enormous. Xylazine is an alpha-2 agonist itself, similar to clonidine or lofexidine. So when a patient is physically dependent on it, they'll experience a severe rebound syndrome upon cessation.
A distinct withdrawal.
A very distinct withdrawal. It includes agitation, severe anxiety, and a rapid heart rate. Because xylazine is an alpha-2 agonist, its withdrawal syndrome specifically benefits from treatment with other alpha-2 agonists.
So we're treating the opioid withdrawal with MO, but we also have to be aggressive with alpha-2 agonists to counteract the xylazine effects.
Simultaneously, you have to use agents like clonidine to counteract the specific, often brutal, rebound from the xylazine.
And we can't forget concurrent benzodiazepine withdrawal, which is a true medical emergency, unlike opioid withdrawal.
That's the critical point. While opioid withdrawal is miserable, benzodiazepine withdrawal is life-threatening. It carries a high risk of seizures and delirium.
This combination really underscores why the inpatient setting is so necessary.
It's not just a convenience. It's a necessity for complex stabilization with its monitoring capabilities and capacity to manage multiple medication titrations safely.
Let's ground this clinical challenge in some hard numbers. If we look across our institutions, how prevalent is opioid withdrawal, really?
It's highly prevalent. It's identified in approximately 1.9% of all hospitalizations. And that rate often relies on proxy measures like ICD-9-CM codes or documented administration of inpatient buprenorphine.
That's nearly 2% of every admission. In a large hospital system, that's a massive volume.
It is. And the growth trajectory of this problem has been steep.
Steep is an understatement.
Opioid-related inpatient hospital stays among U.S. adults increased by 30.8% in just a 6-year period between 2012 and 2018.
And here's the kicker, right? We're probably undercounting it.
We constantly stress that the true prevalence is likely much higher. Opioid use disorder is often overlooked or inadequately recognized during admissions, especially when the patient is admitted for something like trauma or pneumonia.
That under-recognition is a system failure. When a patient presents with a fever and a heart murmur, we quickly suspect endocarditis.
Which is often an associated condition.
Right. But we may miss the underlying substance use disorder until the patient becomes restless or starts asking for pain medication that seems excessive.
Exactly. And that leads us directly to the key high-risk groups we need to be hypervigilant about. We've discussed the fentanyl exposure group, requiring maximal dosing. We've talked about polysubstance users, especially with xylazine.
We also see a significant overlap with severe mental illness.
Yes. Patients with serious mental illness face disproportionately high rates of opioid use. The prevalence jumps to 13.8% in that group.
Which demands a truly integrated care approach.
Right. You have to address the acute withdrawal without sidelining the necessary psychiatric stabilization and vice versa.
Now let's talk about the procedural barriers. This is where system inefficiency directly translates into patient suffering and poor outcomes.
This is a devastating structural problem.
The sources pointed out that patients admitted during nights or weekends face major delays in receiving MOU. Why does this happen?
It often happens because hospital policies, rooted in a fear of diversion or perceived regulatory requirements, insist on confirmation of a patient's community methadone dose from an outpatient clinic.
But if a patient's admitted at 8 p.m. on a Saturday,
That clinic is closed until Monday morning. So this logistical logjam means the patient is left to suffer in escalating withdrawal, sometimes for 36 hours, just waiting for a fax or a phone call that can't happen.
and the consequences of this unnecessary suffering are measurable, they immediately impact patient outcomes.
They are. The most significant quantifiable consequence is patient-directed discharge or leaving against medical advice, AMA.
And how common is that?
It occurs in a staggering 5.6% of all hospitalized patients with OUD. Leaving AMA is associated with dramatically increased risk of readmission, high mortality rates, and interrupted medical care for their acute illness, like a partially treated infection.
But we have compelling evidence that we, as hospitalists, can directly impact this rate. We can fix this with a single intervention.
Absolutely. The data is clear and actionable. Medications for opioid use disorder were associated with a 27% lower risk of patient-directed discharge.
An adjusted odds ratio of 0.73, that's a huge effect size.
It's clinically effective, it saves money by reducing readmissions, and most importantly, it saves lives by keeping patients in treatment.
So here is where I have to challenge the data. If the evidence is this clear, a 27% reduction in AMA risk, why, in one large study, was MOD utilized in fewer than 1 in 4 patients with OUD?
That's the million-dollar question.
Why are 3/4 of our colleagues missing this critical, life-saving opportunity? Is it stigma? Fear of precipitated withdrawal? Lack of institutional infrastructure?
I believe it's a combination of all three, creating a culture of what I'd call therapeutic inertia. First, there's the fear, often exaggerated, of precipitated withdrawal, which leads to overly cautious, inadequate dosing.
Okay.
Second, regulatory barriers, real or perceived, create policy hurdles. Many hospitals require cumbersome consultations with addiction medicine specialists or specialized paperwork, which creates delays.
And the third piece.
A fundamental lack of institutional support. Nursing staff not trained in aggressive withdrawal assessment. Pharmacy protocols that restrict dosing frequency. And sometimes, yes, lingering provider stigma that views these patients as drug-seeking rather than suffering from a chronic, treatable disease.
Our deep dive today is designed to eliminate that first cause, the fear and lack of knowledge.
So we can focus on dismantling the procedural barriers.
To overcome that inertia, we have to be experts at recognition. Let's systematically review the clinical picture. We can group the manifestations of opioid withdrawal into 4 major symptom clusters.
We can. We start where the neurobiology is most active, the autonomic signs. These are the direct reflection of that massive noradrenergic hyperactivity.
So what are we looking for?
We look for pupillary dilation, tearing lacrimation, runny nose rhinorrhea, excessive yawning, piloerection, the physical goosebumps, profuse sweating or diaphoresis, tachycardia, and hypertension. These are often the most objective signs.
The second cluster, the neuropsychiatric symptoms, captures that immense subjective suffering and the craving.
Right. These reflect the dysregulation of the reward circuitry. The patient will be intensely irritable, exhibit severe restlessness, the classic inability to sit still, profound anxiety, insomnia, and, critically, they'll report intense opioid cravings, often coupled with severe dysphoria.
That restlessness, the akathisia, is often what drives patients to leave the hospital.
They feel they cannot stay in their own skin. It's unbearable.
The third cluster involves the gastrointestinal symptoms, which are often the most physically debilitating.
This is due to rebound hypermotility. Chronic opioids dramatically slow the gut. When they're removed, the GI system goes into overdrive.
So we see severe abdominal cramping,
Unrelenting nausea, frequent vomiting, and explosive diarrhea. Hydration status can quickly become a major concern.
and finally, the musculoskeletal symptoms.
Diffuse muscle and bone pain, or myalgias. The withdrawal state causes a loss of the opioid-mediated analgesia and often a state of generalized hyperalgesia. Every joint and muscle aches unbearably.
Understanding the timing of onset is so crucial, especially when deciding when to initiate buprenorphine. It all depends on the pharmacokinetics of the specific opioid used.
Correct. For short-acting opioids like illicit heroin or immediate-release oxycodone, withdrawal typically starts 8 to 12 hours after the last use. The acute phase usually lasts 7 to 10 days.
And fentanyl.
Fentanyl withdrawal, because of its lipophilicity causing that delayed release from fat, is often a little later and less predictable. It typically starts 8 to 24 hours after the last use.
And that uncertainty is what complicates buprenorphine initiation.
Exactly, which we'll discuss soon.
And for the longest-acting opioid we typically manage, methadone.
Methadone withdrawal is the most delayed. It can start up to 30 hours after the last dose, and often much later in deeply tolerant patients. Because of its long half-life, The acute withdrawal phase can last 14 days or even more.
This spectrum of timing emphasizes that our responsibility extends beyond the first 48 hours. The concept of protracted withdrawal syndrome highlights the long tail of this illness.
Absolutely. Even after the acute physical symptoms resolve, the neuroadaptation doesn't just instantly revert. Symptoms like dysphoria, craving, insomnia, and hyperalgesia can persist for weeks to months.
And that represents a massive relapse risk.
A huge relapse risk. This is the underlying rationale for why inpatient management should always include linkage to MODID. Just doing a time-limited detox and sending the patient home during this protracted phase is setting them up for failure.
To monitor this spectrum of symptoms consistently and objectively, we need standardized assessment tools. What are the key scales that have to be utilized on the general ward?
We rely on two primary scales. The first is the Clinical Opiate Withdrawal Scale, or COWS.
This is the clinician-administered one.
Correct. It scores 11 objective signs and symptoms, from restlessness to yawning frequency. Crucially, a COWS score in the range of 12 to 16 is the standard trigger for buprenorphine initiation.
So that confirms the patient is in mild to moderate withdrawal, which minimizes the risk of precipitated withdrawal.
Exactly. If the COWS score is less than 10, initiation is generally considered too risky unless you're using specialized protocols.
And the second tool, the SOWS, provides that subjective counterbalance. It captures the patient's internal experience.
The Subjective Opiate Withdrawal Scale, or SOWS, is patient-reported. This is essential because studies show SOWS scores often demonstrate higher symptom endorsement, and critically, they can detect symptom onset earlier.
How much earlier?
Sometimes more than 10 hours before the observer-rated COWS score starts to rise.
Wow.
So if a patient is scoring high on the COWS but low on the COWS, they are suffering, and you need to watch them closely, knowing that COWS will follow shortly. Plus, SOWS scores have a better association with treatment completion.
So the message is clear. Use both scales together. SOWS for early detection and subjective distress, and serial COWS scores for objective guidance on mood titration.
Exactly. And remember, the COWS score isn't just diagnostic, it's therapeutic guidance. Serial daily COWS scores inversely correlate with the adequacy of your opioid agonist doses.
So if the TOWS score stays high day after day,
You are being too conservative with your mood. You have to rapidly escalate the dose to achieve symptom relief and stabilization.
the diagnosis seems straightforward when a patient volunteers the history, but in real-world practice, symptoms overlap. Opioid withdrawal can mimic several other serious conditions.
Making the differential diagnosis a mandatory step.
Let's start with the other common withdrawal syndromes.
The overlap is substantial, particularly with other depressants. Alcohol withdrawal shares the autonomic hyperactivity, GI symptoms, and anxiety.
But how do you tell them apart?
Alcohol withdrawal is typically distinguished by a coarse, high-amplitude tremor, and, most importantly, it carries a significantly higher risk of seizures, status epilepticus, and delirium tremens. Opioid withdrawal, as a standalone entity, does not usually cause seizures.
And concurrent benzodiazepine withdrawal presents a similar life-threatening overlap.
Yes, substantial overlap in anxiety, restlessness, and severe autonomic signs. But again, like alcohol withdrawal, it's associated with a much higher risk of grand mal seizures and is life-threatening.
So the rule of thumb is?
Assume concurrent benzodiazepine withdrawal until proven otherwise. Prioritize stabilizing that risk, usually with a benzodiazepine taper or phenobarbital. The differentiating factors in pure opioid withdrawal are the prominent lacrimation, rhinorrhea, and piloerection, which are less common in depressant withdrawal.
Moving to non-substance mimics common viral illnesses. How do we quickly distinguish opioid withdrawal from something like gastroenteritis or the flu?
This is a constant issue during flu season. Viral gastroenteritis shares the GI cluster nausea, vomiting, cramping, diarrhea, but it notably lacks the characteristic autonomic signs of opioid withdrawal.
No pupillary dilation, no yawning, no goosebumps.
Right. You won't see that, and you won't see the intense drug craving. Influenza or other acute viral illnesses might share the myalgias and malaise, but they typically feature prominent respiratory symptoms and similarly lack that full autonomic constellation.
And this distinction is so critical because misdiagnosing one for the other can have disastrous consequences if we miss an infection. This brings us to the most important category, the life-threatening mimics.
These are the diagnoses we cannot afford to miss.
It requires a high index of suspicion.
Particularly because our population of patients with OUD often presents with associated infections from injection drug use. First and foremost, sepsis or bacteremia.
Which has a lot of overlap.
It does. It can cause tachycardia, altered mentation, and GI symptoms. For patients with injection drug use, you have to rule out endocarditis, osteomyelitis, or deep tissue abscesses.
What are the absolute red flags that demand a full sepsis workup, even if we strongly suspect withdrawal?
If the patient has concerning vital signs, frank hypotension, a temperature above 38.3 degrees Celsius, or a significantly altered mental status, you must pull the trigger on a full sepsis workup.
Labs should include
Lactate, a complete blood count, and blood cultures. Remember, withdrawal usually causes hypertension, not hypotension. And while patients may feel hot and sweaty, they rarely spike a significant fever, unless an infection is present.
the second life-threatening mimic often has a nearly identical autonomic profile to severe withdrawal.
That is thyroid storm. It presents with a severe overlap, high fever, severe tachycardia, hypertension, intense diaphoresis, anxiety, and GI symptoms.
So what are the differentiating factors?
Usually a higher fever, often exceeding 38.5 degrees Celsius, and signs of end organ damage, like profound heart failure or dramatically altered mental status progressing toward frank delirium or psychosis.
And the workup.
If you suspect it, rule it out immediately with thyroid function tests, TSH, free T4, and free T3. Missing thyroid storm carries a very high mortality rate.
And the third critical mimic, adrenal crisis, which, if suspected, requires immediate empiric treatment.
Right. Adrenal crisis should be on your differential, particularly in patients with a known history of chronic glucocorticoid use. It presents with refractory hypotension, severe GI upset, and often hyponatremia.
So if they suspect it?
You treat immediately with 100 milligrams of hydrocortisone IV. Waiting for confirmatory cortisol levels is not an option. Treat first, confirm later.
Okay, so once we've established a diagnosis and cleared the life-threatening mimics, we move to the treatment strategy. What are the non-negotiable core inpatient goals for managing OUD and withdrawal?
We have to adhere to 4 core goals. First, aggressive symptom relief. This alleviates suffering and is the critical first step in building a therapeutic relationship.
Again.
Stabilization with opioid agonist therapy, MOUD, to treat the underlying substance use disorder,
Third, preventing that patient-directed discharge.
which we know Moody is highly effective at achieving. And fourth, facilitation of care transitions to outpatient treatment. You have to make sure they walk out with their next dose and an appointment secured.
This brings us back to a fundamental paradigm shift. Why is medically supervised withdrawal alone, what used to be called detox, generally considered an outdated and counterproductive approach?
Because acute and especially protracted withdrawal symptoms are the single most powerful trigger for relapse. Simply managing the symptoms for a few days without offering continuation of mode does not address the underlying disorder.
It's a chronic brain disease.
Exactly. When the patient is discharged, they're left highly sensitized and vulnerable, leading to high rates of immediate recurrence of use and, dangerously, an increased risk of fatal overdoses because their tolerances drop slightly.
So if supervised withdrawal isn't the standard, when is it indicated as the sole treatment pathway?
It's only indicated in 2 specific scenarios. First, when a patient explicitly and autonomously chooses not to use opioid agonists, which is their right. And second, when a patient is actively transitioning to extended-release naltrexone.
Which is a mu-opioid receptor antagonist.
Right, so naltrexone requires a complete washout period of all opioids, making medically supervised withdrawal necessary to ensure abstinence before you start it. Otherwise, the standard of care is stabilization and maintenance using opioid agonist therapy.
Which brings us to the first line, pharmacologic management, MOU.
High-quality, randomized controlled evidence overwhelmingly supports using either buprenorphine or methadone as first line for acute withdrawal stabilization. This is true whether the patient intends to continue no-do long-term or not.
So the inpatient stay is our high-value window to initiate this therapy aggressively.
Regardless of the patient's long-term plan, it ensures their immediate safety and retention in care.
Let's delve into the mechanics of our 2 first-line agonists, starting with methadone. What are its defining advantages and the current protocols we must follow, especially given the high tolerance of the Fentanyl-Era?
Methadone is a full agonist at the mu-opioid receptor. That means it provides complete receptor stimulation, and critically, it has no ceiling effect on its efficacy.
Which makes it uniquely useful for patients with the most severe withdrawal or the highest degree of opioid tolerance.
Which is increasingly common with fentanyl exposure.
And its key logistical advantage is bypassing the risk of precipitated withdrawal.
Yes, that is its single biggest advantage. Because it's a full agonist, methadone can be initiated before withdrawal symptoms even begin, or at any time, creating no risk of precipitated withdrawal.
It eliminates the need for that careful timing and scale monitoring.
Right. However, the sources emphasize that traditional outpatient doses are just insufficient for the current fentanyl-exposed population.
So how must we adapt our inpatient methadone titration protocols to be truly aggressive?
The tolerance levels are unprecedented. Traditional guidance often suggested starting at 20 to 30 milligrams a day. But for a patient with high fentanyl tolerance, initiation often starts with 30 to 40 milligrams orally.
And then you titrate rapidly.
And aggressively. In the inpatient setting, where the patient can be monitored, this often means 5 or 10 milligram increases every 4 to 6 hours, as long as the patient continues to show signs of withdrawal.
Confirmed by a persistently high COWS score.
And as long as they remain hemodynamically stable, the goal is to reach symptomatic relief within 24 to 48 hours, not 5 days.
That aggressive titration comes with mandatory safety considerations due to methadone's complex pharmacokinetics. This is where we need technical vigilance.
Absolutely. Methadone has a famously long and highly variable half-life. It can range from 5 hours to potentially 130 hours.
Which means it accumulates over several days.
Yes. And critically, its respiratory depressant effects peak later and last longer than its analgesic and withdrawal suppressing effects.
So a patient might feel comfortable initially, but then experience oversedation or respiratory compromise a day or two later as the drug accumulates.
That's the danger. So we must enforce close monitoring for oversedation and, importantly, QTC prolongation.
Right. Methadone is known to prolong the QTC interval.
Especially at higher doses. So an EKG should be performed at baseline. And again, once the patient is on a stabilized dose, typically around 100 milligrams daily, or if they're symptomatic, daily assessments of peak sedation levels are non-negotiable.
The major regulatory constraint, of course, is that methadone withdrawal management must be done in an inpatient setting or through a federally licensed opioid treatment program.
Correct. This contrasts sharply with buprenorphine,
Which has a much more flexible regulatory profile.
which is why it's become the preferred agent for many hospitalists. It's a high-affinity partial agonist. It binds extremely tightly to the mu-opioid receptor, but only activates it partially.
And that partial agonism is the source of its massive safety advantage, the ceiling effect on respiratory depression.
It dramatically reduces the risk of respiratory arrest compared to a full agonist, like methadone or heroin. But that partial agonism is also the source of its major clinical limitation.
The initiation limitation.
The biggest hurdle we face. As a high-affinity partial agonist, buprenorphine can displace any full agonist opioid like fentanyl that is currently occupying the receptor.
And if it displaces a full agonist and replaces it with a partial agonist,
The net receptor activation drops suddenly, triggering severe, acute, precipitated withdrawal, often within an hour of administration.
let's use an analogy here to make that mechanism clear, because that fear is the primary barrier to opioid utilization.
Okay, think of the opioid receptor as a car engine. A full agonist, like fentanyl, is stepping fully on the gas pedal full activation.
And buprenorphine.
Buprenorphine is like a key that fits the ignition perfectly, but only allows the engine to idle partial activation.
So if fentanyl is actively pressing the gas pedal and you violently insert the buprenorphine key,
It shoves the fentanyl key out. The engine suddenly drops from full speed to idle, causing the body to experience a severe, acute crash.
so buprenorphine only alleviates withdrawal in patients who are already experiencing at least mild to moderate withdrawal symptoms.
We need that COWS score to be reliably greater than 10 to minimize the risk.
And the fentanyl factor, with its lipophilicity and unpredictable timing, complicates this assessment even further.
It does. This is a major area of clinical innovation. Patients exposed to fentanyl have reported increased risk of precipitated withdrawal despite 12 to 48 hours of abstinence, which used to be enough for heroin.
Fentanyl just lingers too long, so how are clinicians attempting to mitigate that specific risk?
We're seeing the emergence of highly specialized protocols like the Bernese method or microdosing initiation.
Unpack the Bernese method for us. How does microdosing buprenorphine mitigate that risk?
The Bernese method involves introducing tiny, minuscule amounts of buprenorphine, starting as low as 0.25 milligrams, sometimes even less, while the patient remains on their full agonist.
So you're overlapping them?
Right, you overlap. The dose is then gradually increased over 5 to 7 days. Because the initial doses are so small, they don't displace enough full agonists to trigger withdrawal. The partial agonist slowly accumulates, and by the time you reach therapeutic doses, the brain is slowly adapted.
A smooth transition.
It's a game changer for the fentanyl patient who cannot tolerate 24 hours of abstinence.
That is a perfect example of a nuanced, high-yield clinical nugget. But what about the extreme cases? The sources mention the need for short-acting, full agonist opioids, or SAFO, for highly tolerant patients. Where does that fit in?
This is a crucial evolving concept for extreme tolerance. For some patients exposed to high-dose fentanyl, even aggressive methadone or buprenorphine is initially insufficient to stabilize them.
They're withdrawing too rapidly and severely.
Right. They need temporary high-dose full agonism to break the cycle. The use of SAFO short-acting full agonist opioids like oxycodone or morphine serves as a temporary bridge.
So we're using a full agonist, but under controlled hospital conditions, to achieve initial stabilization before transitioning them fully to MOD.
Precisely. One safety net hospital study noted that patients were receiving an average of 278 milligrams oral morphine equivalents daily of SAFO during the first week, even when they were also on MOD.
That's a huge dose.
And this aggressive supplementation was associated with reduced withdrawal severity and fewer adverse events. The implication is clear. For the highest tolerance patients, we may need to accept the temporary use of high-dose SAFO to achieve comfort and stabilization.
Followed by a rapid taper of the SAFO once the MOD has reached steady state.
Exactly. It's a compassionate, evidence-driven acknowledgement of the severity of fentanyl tolerance.
Mallow addresses the underlying deficit, but the withdrawal syndrome is multisystemic. What role do non-opioid medications play, and when are they acceptable as monotherapy?
They are essential critical adjuncts, but generally they should never be used as monotherapy if an opioid agonist is available and acceptable to the patient.
So what's the most evidence-based non-opioid approach?
It involves the alpha-2 adrenergic agonists, as they directly counteract that central noradrenergic hyperactivity which causes the classic physical signs.
These are our workhorses for the autonomic signs. Tell us about the two main agents and why one is increasingly preferred.
We rely on clonidine and lofexidine. These agents are highly effective at reducing the autonomic cluster, the sweating, the tachycardia, the hypertension, and the anxiety.
And lofexidine is increasingly preferred.
Yes. Lofexidine is particularly relevant as it is the only non-opioid agent that is FDA approved specifically for the mitigation of opioid withdrawal symptoms. It offers a more favorable side effect profile than clonidine.
Specifically, less hypotension and sedation.
Right, which allows us to dose it more aggressively without the risk of causing orthostatic collapse.
And how is clonidine typically dosed? What are the cautions?
Clonidine is often initiated at 0.1 to 0.3 milligrams every 6 to 8 hours, with a max dose around 1.2 milligrams daily. The primary caution is its hypertensive effect.
So you have to check orthostatics before each dose.
You do. And hypotension is the main factor that limits our ability to achieve adequate doses for withdrawal relief.
You mentioned earlier that alpha-2 agonists have a dual role, especially with the polysubstance crisis. They're critical for concurrent xylazine withdrawal.
That's a key piece of high-yield information for current practice. Because xylazine is itself an alpha-2 agonist, its cessation causes a severe rebound syndrome. So patients with concurrent xylazine withdrawal require aggressive dosing of clonidine or lofexidine.
And we also have to manage the skin lesions from xylazine.
Yes, Xylazine causes specific severe necrotic skin lesions unrelated to the injection site, which require diligent wound care during the inpatient stay. It adds another layer of complexity.
So to summarize their clinical role, they are adjuncts to MOD, or primary therapy only if MOD is declined.
Exactly. They're definitely more effective than placebo, but head-to-head trials show they are generally not as effective as MOD, like a methadone or buprenorphine taper, in achieving complete symptom reduction and long-term treatment completion.
They treat the symptoms.
But not the underlying brain disease.
Finally, let's quickly review the symptomatic medications, which strictly serve as adjuvants to target specific breakthrough symptoms.
These should never be used as monotherapy. They're just there to optimize comfort. For the GI cluster, we use loperamide for diarrhea, ondansetron or other antiemetics for nausea, and dicyclamine for abdominal cramping.
And for the diffuse muscle and bone pain, the myalgias,
we turn to non-steroidal anti-inflammatory drugs, or NSAIDs, and acetaminophen.
And for the severe anxiety and insomnia that persists despite the primary treatment,
Trazodone is a useful agent for sleep disturbance because it's not addictive. Benzodiazepines can be utilized for severe anxiety and muscle cramps, but they must be used with extreme caution.
especially due to the risk of respiratory depression if combined with agonists.
Exactly. They should be used sparingly and only for breakthrough symptoms.
That brings us to a comprehensive close on the management strategy. Before we finish, let's crystallize the core takeaways for our listeners.
The three core principles are, first, aggressive treatment is mandatory. Untreated withdrawal drives adverse outcomes, including that devastating 27% higher risk of patient-directed discharge.
Second, MOUD is the standard of care.
Use methadone for the highest tolerance patients, or definite fentanyl exposure when you can't afford the delay. Use buprenorphine when confirmed withdrawal symptoms. COWS greater than 12 allows safe initiation, or consider microdosing protocols for complex fentanyl patients.
And third, the inpatient stay is a high-stakes, crucial intervention opportunity.
Use it to stabilize, optimize mood, and secure that linkage to long-term treatment.
We've spent a lot of time today focusing on the evidence we do have, but it's crucial to acknowledge the massive evidence gap that continues to challenge us.
Especially in the face of the ever-evolving nature of the illicit drug supply.
It's the honest reality of frontline hospital medicine right now.
It is. To date, there is no large-scale, prospective, randomized evidence to specifically guide opioid withdrawal management from fentanyl. Our current aggressive strategies, like using SAFO for highly tolerant patients, or the rapid adoption of protocols like the Bernese method, are necessary innovations driven by clinical urgency.
Not level 1 evidence.
Not yet. This underscores the need for continuous vigilance and adaptation in hospital medicine. We are essentially running a fast-moving, continuous clinical trial on the wards, and we must rapidly integrate emerging evidence and innovative protocols to meet the severity of today's fentanyl crisis.
So the final thought for you, the listener, to mull over is this. As the potency and unpredictability of illicit opioids continue to rise, how do we reconcile the need for evidence-based medicine with the immediate urgent need for compassionate, aggressive clinical innovation? The answer likely lies in institutionalizing rapid response protocols like microdosing initiation to ensure we never again allow a patient to suffer unnecessarily due to a rigid, outdated policy that was designed for a different era of the opioid crisis.